Hello everyone. Today is our OCT, the third session of the series of open courses. Let's discuss together, in the real-world clinical practice, how to properly conduct the prioritization of imaging and physiological examinations. This is actually a very broad topic. It was a topic I presented at one of the previous Oriental Congress of Cardiology. I have reorganized it myself to share it with you. The first part will focus on the classification of imaging and physiological modalities and their respective advantages and disadvantages. Then we will explore how to define whether a lesion causes ischemia. In addition, if the patient has multiple lesions, how should we define the culprit lesion and decide which one to treat? Finally, we will discuss how to use imaging examinations to optimize the PCI procedures. Let's first look at a clinical case. This patient suffered from angina. During angiography, we observed the circumflex artery. From projections such as the spider view and cranial views, we could see that at the distal end of the left main coronary artery, the ostia of the two branches had obvious plaque formation. In the cranial view, we could see that the mid-segment of the left anterior descending artery had a very severe stenosis. Therefore, from both anatomical and functional perspectives, it was obviously abnormal and active. Interventional therapy was indicated to relieve symptoms. This patient underwent an Ivers examination. We could see that, in the proximal segment of the LAD, the plaque burden was relatively high. In the mid-distal segment, the lesion, which appeared to be a borderline lesion, had a very high plaque burden. Additionally, there was a large lipid-rich plaque. Therefore, for this patient PCI was performed, which should be relatively uncontroversial. However, some patients may have unexpected findings. Let's look at the right coronary artery, RCA. For this RCA, the proximal segment had a very severe stenosis. Based on the degree of stenosis alone, stenting would be indicated, which should not be highly controversial. An FFR measurement was performed, which showed a value of 0.51. This value indicates very severe myocardial ischemia, so PCI is certainly justified. The second case involves the circumflex artery and LAD. In their mid-distal segments, both had very severe stenosis. Based solely on the degree of stenosis, both lesions were 80 to 90% stenotic. So interventional therapy might be considered for both. From the perspective of the LAD, the FFR value of the patient was 0.45, so PCI is clearly indicated. However, the FFR of the circumflex artery was 0.89, indicating excellent vascular function. This situation poses significant clinical confusion. For patients with such moderate stenosis, should we perform interventional therapy or not? When anatomical findings and functional assessments are inconsistent, how should we make treatment decisions? In real-world clinical practice, as clinicians we may face a major challenge: how to balance the complementary relationship between anatomy and function. We need to understand the relationship between immediate post-PCI outcomes and long-term efficacy. From an anatomical perspective, we can assess lesions well, using indicators such as diameter and area stenosis rate. However, some patients with seemingly severe anatomical lesions actually have favorable FFR values, while some patients with mild anatomical stenosis also have good FFR values, but have high plaque burden. Additionally, if the plaque is identified as vulnerable plaque, whether such patients require treatment requires comprehensive assessment, combining functional and imaging modalities in clinical practice. For example, before PCI, we need to identify the culprit vessel, especially in patients with multiple lesions. In addition, for a single patient with multiple lesions in the same vessel, we need to determine which one is the culprit lesion. During the procedure, we need to evaluate the pathological basis of the plaque and formulate corresponding treatment strategies. Because plaques can be either ruptured or erosive, and these two types require different treatment strategies. After the procedure, we need to assess stent apposition and decide whether non-culprit lesions or vessels require concurrent treatment, which has long been controversial. In cases of in-stent restenosis, ISR, we need to identify its causes and evaluate the degree of intimal hyperplasia, as well as formulate remedial measures. These are all practical challenges we face in clinical practice. That's all for today. Thank you.